Good morning to respected teachers, seniors, and colleagues. Today's topic for seminar is anticholinesterase agents. First of all, acetylcholinesterase. It is type B carboxyl esterase enzyme. It is also known as acetyl hydrolase. It is the primary cholinesterase in the body which hydrolyzes acetylcholine and other cholinesters. Structure of acetylcholinesterase. Each molecule has an active surface with two important binding sites, an anionic site and an steric site. Negatively charged anionic site on acetylcholinesterase molecule is responsible for electrostatically binding the positively charged quaternary nitrogen group of the acetylcholine molecule. Steric site forms covalent bonds with the carbamate group of the opposite end of acetylcholine molecule and is responsible for the hydrolytic process. A secondary or peripheral anionic site has been proposed. Binding of ligands to peripheral anionic site result in inactivation of the enzyme. Classification of anticholinesterase agents. Compounds which reversibly inhibit the acetylcholinesterase enzyme are carbamates, which include physostigmine, neostigmine, pyridostigmine, and rivastigmine. Non-carbamate quaternary ammonium is hydrophonium, acridine, which is tacrin, and donepezil. In irreversible inhibitors are organophosphorus compounds, which are parathione and malathione. Reversible inhibitors react slowly, whereas irreversible inhibitors react extremely slow or they do not react at all. Androphonium and tacrin bind at anionic site only, and no covalent bond is formed. On the other hand, organophosphates attach only at steric site, forming covalent bond. Half-life of reactivated carbamylated enzyme is nearly 30 minutes, which is lesser than synthesis of fresh enzyme, whereas half-life of phosphorylated enzyme is in days, which is greater than regeneration time of the fresh enzyme. Androphonium has short duration, nearly 10 minutes, because no hydrolysis occurs and it is rapidly eliminated by renal excretion. Irreversible inhibitors undergo aging within the period of 1 to 2 hours. Acetylcholinesterase and drug complex undergoes molecular rearrangement and it becomes completely resistant to hydrolysis. They undergo aging by loss of alkyl or 1-alkoxy group and become resistant to hydrolysis. DFP is more prone to hydrolysis compared to parathione or malathione. Molecular mechanism of cholinesterase inhibitors. Three distinct domains on ACHE constitute binding sites of inhibitory ligands. First is acetyl pocket of active center. Donepezil binds with this site. Second is choline subsite of active center, where hydrophonium and tacrin binds. Third is peripheral anionic site. Propidium binds here. Chemistry and structure activity relationship. First is non-covalent inhibitors. They interact by reversible and non-covalent bonding with active site in cholinesterase. Androphonium has moderate affinity for acetylcholinesterase and its action is limited to peripheral nervous system synapses. its volume of distribution is limited and high renal clearance is leading to short duration of action. Tacrine and donepezil have higher affinities for acetylcholinesterase. They are hydrophobic, they crosses blood-brain barrier and therefore they are active in CNS and they are long-acting. Reversible carbamate inhibitors. Carbamylating inhibitors with high lipid solubility have long duration of action. They cross blood-brain barrier and therefore they are used as an alternative treatment in Alzheimer's disease. Organophosphorus compounds. Diisopropyl fluorophosphate produce virtually irreversible inactivation of acetylcholinesterase by alkyl phosphorylation. They are highly lipid soluble, low molecular weight, and transdermal absorption. These compounds also penetrate into CNS. Basis of pharmacological effects of cholinesterase inhibitors. They potentiate and prolong the effects of acetylcholine by prevention of hydrolysis at sites of cholinergic transmission. The anticholinesterase agents potentially can produce all of the following effects: stimulation of muscarinic receptor responses at autonomic effector organs, stimulation followed by depression or paralysis of all autonomic ganglia and skeletal muscle. Third is stimulation with occasional subsequent depression or pre and post synaptic cholinergic receptor sites in the CNS. Now we will see effects on physiological systems. First is eye. The anticholinesterase agents cause conjunctival hyperemia, miosis, constriction of ciliary muscles leading to block of accommodation reflex resultant focusing in near vision. Effects on GI tract. They enhances gastric contractions, increase secretion of gastric acid, salutary increase in tone and peristalsis, and dilation of esophagus. They augment motor activity of small and large bowel. Effects on neuromuscular junction. They reverse antagonism caused by competitive neuromuscular blocking agents. Contrastingly, neostigmine is not effective in skeletal muscle paralysis caused by succinylcholine. Succinylcholine produces neuromuscular blockage by depolarization. Neostigmine will enhance depolarization and resultant blockage. Effects on cardiopulmonary system. Predominant effect on heart is bradycardia, which results in fall in cardiac output. Higher doses enhances the fall in blood pressure. These agents also augment vagal influences on heart. Actions at other sites. At lower doses, these agents augment secretory responses to nerve stimulation in glands and at higher doses increase in resting rate of secretion of glands. These agents increase contraction of smooth muscle fibers of the bronchioles and ureter. Reversible anticholinesterases. Reversible or competitive inhibitors of acetylcholinesterase. Reversible anticholinesterase drugs bear a structural resemblance to acetylcholine. They combine with anionic and esteric sites of acetylcholinesterase. The drug acetylcholinesterase complex is less readily hydrolyzed than acetylcholinesterase and acetylcholine complex. This results in temporary inhibition of the enzyme because acetylcholinesterase regeneration is taking a longer time. Natural alkaloids, physostigmine, also called as acerine, naturally occurring alkaloid obtained from dried ripe seeds of Physostigma venenosum. Being a tertiary amine, it is highly lipid soluble and shows better absorption in all body compartment including CNS. It has marked muscarinic effect M1 to M3, also stimulates ganglia, but its nicotinic effect at motor and plate is negligible. Being highly toxic, it has only limited uses. Rest of the drugs are synthetic quaternary ammonium compounds, therefore they cannot cross blood-brain barrier. Synthetic quaternary compounds, they are adrophonium, neostigmine, pyridostigmine, diastigmine, embenonium, and dimethicurium. Being quaternary compounds, they are least absorbed and they do not cross blood-brain barrier. Important therapeutic and toxic effects on skeletal muscle neuromuscular junction. At low doses, they moderately prolong and intensify the action of physiologically released acetylcholine at motor and plate. They strengthen the muscles which are weakened by curare-like drug or by myasthenia gravis. Their effectiveness in therapy of myasthenia gravis is based on direct agonistic action on NM receptors. Irreversible anticholinesterases. Irreversible inhibitors of anticholinesterase. They are pentavalent organophosphorus compounds such as diflose, ecothiophat, and parathion. They have labile groups. Diflose has fluoride and ecothiophat and parathion have organic group as labile group. These agents bind at steric site. During the process, the labile group is released, leaving remaining part of the drug molecule attached covalently with steric site of the acetylcholinesterase through its phosphorus atom. The enzyme is phosphorylated. After phosphorylation, the acetylcholinesterase becomes inactive and is usually very stable. It is resistant to hydrolysis due to covalent bonding. Irreversible inhibitors organophosphates combines with steric site of anticholinesterase enzyme. The enzyme is phosphorylated, which is very resistant to hydrolysis. This results in prolonged action of acetylcholine. The effect of the organophosphate agents depend upon regeneration of the new enzyme. Irreversible inhibitors of an acetylcholinesterase. They are volatile, non-polar substances with very high lipid solubility. They are rapidly absorbed through mucous membranes and even through unbroken skin. They are mainly used as insecticides or pesticides. Diflose is diisopropyl fluorophosphate. It is potent and long-acting anticholinesterase. Its use as meiotic is obsolete now. Ecothiophat is quaternary ammonium compound. It is water-soluble and does not cross blood-brain barrier. 0.05% to 0.25% solution is used topically as meiotic and in the treatment of glaucoma. It is potent and longer acting. It gives decreased intraocular pressure for 1 to 2 weeks. Carbaryl is carbamate derivative. It has low toxicity from dermal absorption. It is used as topically for control of head lice. Therapeutic uses of acetylcholinesterase inhibitors. Paralytic ileus and atony of urinary bladder. Neostigmine is used for relief of abdominal distension and acute colonic pseudo-obstruction for variety causes. In postoperative paralytic ileus, the peristaltic activity commences after 10 to 30 minutes of parenteral administration of neostigmine, whereas 2 to 3 hours after oral administration of neostigmine. A similar dose is also used for treatment of atony of detrusor muscles of bladder for postoperative dysuria. It should not be used in intestine or bladder obstruction, peritonitis, where viability of bowel is doubtful, and in inflammatory bowel disease, glaucoma, and other ophthalmic indications. Glaucoma is complex disease characterized by increase in intraocular pressure. Management of glaucoma. Primary glaucoma is associated with direct disturbances in outflow of aqueous humor, and it is subdivided into narrow angle or close angle acute congestive or angle closure glaucoma. The other is wide angle, which is also called as open angle chronic simple glaucoma. Narrow angle glaucoma, it is medical emergency because there is rapid rise in intraocular pressure. Patient comes with painful red eye, sweating, headache with nausea and vomiting. Drugs can control acute attack of narrow angle glaucoma, but long-term management is needed. Partial iridectomy or placement of hole in the peripheral iris by laser. Wide angle glaucoma. Trabecular meshwork starts losing patency due to progressive degeneration. Consequently, the outflow of aqueous humor gets impeded. Surgical intervention is not useful in management of wide-angle glaucoma. We need to control the intraocular pressure with long-range drug therapy. In wide-angle glaucoma, contraction of longitudinal ciliary muscle which stretches trabecular meshwork and open the tubules to facilitate the drainage of aqueous humor will decrease in intraocular pressure. The treatment is 0.5% pilocarpine. If alone is not effective, then we need to give physostigmine with pilocarpine. Myasthenia gravis. It is a neuromuscular disease. It is characterized by exacerbations and remissions of weakness and marked fatigability of skeletal muscle. Clinical presentation. The characteristic feature of myasthenia gravis is weakness of muscle and fatigue that worsens after exercise, but it is goes off after rest. At early stages, fast-moving muscles are affected, such as eyelid, extraocular muscles, facial muscles, and pharyngeal muscle. The symptoms start with ptosis, diplopia, slurring of speech, difficulty in swallowing, and weakness of extremity. Progressively, all muscles get involved, including respiratory muscles. In 75% cases, thymus shows pathological abnormality. This substantiates immunological etiology of the disease. Ameliorative test. Initially, 2 mg edrophonium is injected IV as a test dose. If nothing untoward happens, remaining 8 mg is injected after 30 to 60 seconds. In myasthenia gravis, reversal of weakness and short-lasting improvement in strength of affected muscle occurs. In case edrophonium is not available, 1.5 mg IV neostigmine is used. To block the muscarinic effect of neostigmine, pretreatment with atropine is given. Management. Neostigmine. The dose and frequency is adjusted for optimum relief. Dosage requirement of neostigmine fluctuates. Pyridostigmine and embinonium is also used. Atropine is added to block intolerable muscarinic side effects. Treatment of myasthenia gravis. Acetylcholinesterase inhibitors have no effect on basic disorder, which often progresses. Ultimately, it is not possible to restore muscle strength adequately with anticholinesterase alone. Corticosteroids have immunosuppressant actions. Prednisolone induces remission in about 80% of the advanced cases. Other immunosuppressants such as azathioprine and cyclosporine inhibit NR antibody synthesis by affecting T cells. The other therapeutic approach is removal of antibodies by plasmapheresis. Dramatic but short improvement can be achieved. Thymectomy is effective in majority of cases. It produces gradual improvement and complete remission. After prolonged treatment or with overtreatment, patient's condition may swing, which is due to therapeutic failure as a consequence of low dose or toxicity due to overtreatment by higher doses. In both conditions, patients have muscular weakness. So, myasthenic crisis and cholinergic crisis both lead to muscle weakness and both require opposite treatment. So, differentiation is needed. The differentiation is done by hydrophonium test. We inject 2 mg hydrophonium IV. If improvement occurs, it is myasthenic crisis, and if no improvement or worsening occurs, it is cholinergic crisis. Myasthenic crisis is characterized by acute weakness of respiratory muscles. Therefore, tracheal intubation and mechanical ventilation is needed. IV methylprednisolone first therapy is given while anticholinesterase are withheld for 2 to 3 days, followed by their gradual reintroduction. Plasmapheresis hastens the recovery. Alzheimer's disease. It is neurodegenerative disorder primarily affecting cholinergic neurons in brain. It is characterized by progressive dementia. In the treatment, relatively cerebroselective anticholinesterase agents are used, such as rivastigmine, donepezil. Galantamine is natural alkaloid inhibitor with additional weak agonistic action on nicotinic receptors. Tacrine is lipophilic acridine compound. It is longer acting and it gives symptomatic relief. The side effect is hepatotoxicity. Belladonna or datura poisoning. Physostigmine is specific antidote. It is tertiary amine alkaloid. It crosses blood-brain barrier. It antagonizes central and peripheral toxicity of atropine. The diagnosis is made by giving smaller doses of physostigmine 0.5 to 1 mg IM. If no parasympathomimetic effect of physostigmine such as flushing, sweating, salivation, lacrimation are observed, it is a case of atropine poisoning. Atropine poisoning is treated by giving physostigmine. The side effects are hypotension, arrhythmia, undesirable central effects. Neostigmine is less risky than physostigmine because it does not block central effects. Other uses are poisoning with any other anticholinergic drugs, tricyclic antidepressants. Other uses are postoperative decurarization. Neostigmine is given along with atropine. It rapidly reverses muscle paralysis induced by competitive neuromuscular blocker. Second is cobra bite. Cobra venom is curare-like neurotoxin. Primary treatment is specific antivenom serum. To prevent respiratory paralysis, neostigmine and atropine are given. Paroxysmal atrial and supraventricular tachycardia. Atrophonium can be given, but calcium channel blocker are preferred. Toxicology. Toxicity of reversible anticholinesterase drugs. They have nicotinic side effects and muscarinic side effects. Muscarinic side effects include flushing of face, salivation, sweating, lacrimation, nausea, vomiting, abdominal cramps, and bronchoconstriction. Nicotinic side effects include muscle fasciculation, twitching, muscular weakness, and tremors. Treatment of side effects. If muscarinic symptoms are predominant, they are treated by atropine 0.5 mg subcutaneous. But neostigmine toxicity itself is identified by muscarinic manifestation. Non-judicious use of atropine may mask its muscarinic side effect. Patient may suddenly pass into the state of cholinergic crisis. Moreover, tolerance to muscarinic side effect due to anticholinesterase drug eventually develops at a later stage. Therefore, atropine treatment is not necessary. Organophosphorus poisoning. Anticholinesterases are easily available. They are extensively used as agricultural and household insecticides. Poisoning occurs either due to occupational or accidental or suicidal reasons. Manifestations of toxicity. Local muscarinic manifestations at exposure site occurs immediately. They are followed by complex systemic effects due to muscarinic, nicotinic, and central actions. Manifestations of toxicity of organophosphates. Muscarinic toxic manifestations include diarrhea, urination, lacrimation, salivation, meiosis, bronchoconstriction, sweating, bradycardia, and hypotension. Nicotinic toxic manifestations include fasciculation of skeletal muscles leading to paralysis. CNS toxic manifestations include restlessness, tremors, convulsion, ataxia, and respiratory arrest. Delayed toxicity of organophosphates. Prolonged exposure to organophosphorus compounds can cause neurotoxicity. OPIDN, known as organophosphorus compounds induced delayed neurotoxicity, is due to binding of OP compounds covalently to the enzyme called NTE, neuropathy target esterase active site. It is neurodegenerative disorder characterized by ataxia processing to paralysis with a concomitant central and peripheral distal axonopathy in association with phosphorylation of a second enzyme NTE. Management of organophosphorus compounds toxicity. First is termination of further exposure to poison. According to the site of the exposure, we need to give fresh air, wash the skin and mucous membrane with soap and water, or do gastric lavage. Second is maintenance of patent airway, positive pressure respiration if it is failing. Third is supportive measures, maintain BP, hydration, and control of convulsions with judicious use of diazepam. Fourth is specific antidote. Atropine can counteract muscarinic and central side effects. Other is cholinesterase reactivators. 2-PAM, pyridine 2-aldoxame methyl chloride, obidoxime, or diacetyl monoxime. Atropine is highly effective in counteracting the muscarinic symptoms. Higher doses required to antagonize the central effect. It does not reverse peripheral muscle paralysis because it is a nicotinic action. 2 mg IV is repeated every 10 minutes till dryness of mouth or other signs of atropinization appears. Maximum 200 mg per day can be given. The maintenance dose is required for 1 to 2 weeks. Cholinesterase reactivators, oximes. Organophosphate compounds inactivate cholinesterase by phosphorylating ester site of the enzyme. Oximes bind with high affinity to anionic site and dephosphorylate the enzymes at the ester site, thus reactivating them. Early administration of oxime is necessary before the phosphorylated enzyme undergoes aging and becomes resistant to hydrolysis or reactivation. Cholinesterase reactivator pralidoxime. Cholinesterase plus organophosphate plus pralidoxime. Pralidoxime bind to free anionic site. Oxime group attracts the phosphate. Oxime phosphonate complex diffuses out and free active cholinesterase is obtained. Pralidoxime can't reactivate cholinesterase inhibition by carbamates because anionic site is not free. Pralidoxime, it is injected IV slowly. Loading dose is followed by continuous infusion till recovery. Doses repeated according to the need. Low doses are need to be continued according to the symptoms for 1 to 2 weeks. Other oximes are obidoxime, which is more potent than pralidoxime, and diacetylmonoxime, which is lipophilic. Limitations to the use of oximes. First is reactivation of the phosphorylated acetylcholinesterase is no longer possible if it has undergone the process of aging because it is resistant to hydrolysis. Pralidoxime and obidoxime do not cross blood-brain barrier. They cannot reactivate acetylcholinesterase inhibited in the brain, whereas diacetylmonoxime has an advantage of crossing blood-brain barrier. Pyridoxine is ineffective as antidote to carbamate group of anticholinesterases because carbamates attach with anionic site as well as ester site of acetylcholinesterase. So, anionic site of enzyme is not free to provide attachment to the oxime reactivators. These are the references I have used. Thank you.